Welcome, everybody. This is Avoiding the Addiction Affliction, brought to you by Westwards Consulting and the Kenosha County Substance Use Disorder Coalition. I'm Mike McGowan. Today, we're going to have yet another conversation about opiates and fentanyl in particular. We're going to discuss the reasons fentanyl continues to be a tremendous problem. Our guest today is Dr. Phillip Randy. Oh, Randy, I just spaced it. Say your last name.
TORRALVA.
TORRALVA. You learn this stuff and then you mess it up, but that's all right. Dr. TORRALVA is a board-certified anesthesiologist and specialist in addiction medicine with over 30 years in clinical medicine. He has extensive expertise in pharmacology, invasive monitoring, and central nervous system drug delivery of potent opioids and anesthetic agents, specifically fentanyl and its analogues. In 2018, seeing the need for new treatments for fentanyl and fentanyl analog overdose treatment, he started, say it again,
TORRALVA. Oh,
TORRALVA Medical Therapeutics. We're going to call it TMT from now on, and began self-funded contract research with the Portland Veterans Administration to investigate the underlying molecular mechanisms of fentanyl toxicity. Well, welcome, Randy. I'm so thankful you prefer to be called Randy. So
it's a lot easier for all of us, Mike.
TORRALVA, just so you all know I can get it right. All right. First, I want to start with some basic. You were an anesthesiologist for about 20 years, long before the opioid crisis hit, right?
Yes, that's right. So, I was in practice for about 20 years in a small Central Coast California town and was pretty happily ensconced in my practice there. And what happened was we had an interesting, sad, tragic series of events. We had 3 fentanyl overdose deaths that happened in a very close time frame in 2015.
Wow.
And yeah, that immediately, it's a small town. And so it really brought all of our attention to fentanyl and to the opioid crisis. And suddenly that was my first awareness that fentanyl had actually taken over the opioid crisis.
Well,
And yeah.
we're going to talk about that, but I just had surgery again. I
Mhm.
say again. I feel like anesthesiologists are my best friends sometimes. When you go in, like most people, they ask you all sorts of questions, right? Height, weight, a sensitivity, done this before, et cetera, et cetera. Why?
Yeah, great question, Mike. And that's the interesting thing about anesthesia, and what makes it so complicated is that everyone is slightly different in how they respond to the anesthetic drugs that we use. And we, anesthesiologists in general, we're experts in pharmacology and physiology. And what we need to know about a person before we actually provide the anesthetic for them is, height, weight, their baseline medical issues or medical problems, any allergies that they've had, or negative reactions to anesthetics or different medications in the past. And that all kind of comes into our assessment of what we can use for that patient and how careful we have to be in administering different agents that we use. And so we've kind of learned, we have an arsenal of medications that we use in the operating room. We essentially learn to master those and then understand how an individual's physiology and their baseline medical issues may actually change their interaction with those drugs. And so everybody's a little different. And so that's what makes anesthesia challenging and quite complicated in some cases.
I can't be alone in this, but I understand it's not the norm. I snap out of that stuff like really easy, and I tolerate it very well. I understand some people get nauseous or sick. I just want a chocolate shake when I come out of surgery. But do you know ahead of time which chemical combination you're likely to use?
Yeah, great question. So a lot of the medications that we use are fairly standard that we use across a large grouping of patients. But some patients are so ill that we have to really tailor and change up some of the anesthetics that we use. We definitely have to evaluate each person. And you're very fortunate in that some patients, when I give an anesthetic, no matter what I give them, no matter what I try to, what preventive methods I use to prevent them from getting nauseous or ill, they just have a negative reaction to anesthesia. And it's one of those things. It's certainly, again, one of the challenges that we face with administering anesthetics to patients.
Well, let's get into the meat of the matter now. Among other drugs, you use fentanyl occasionally. What's the difference between fentanyl used in anesthesia and the other chemical compounds?
So fentanyl is actually one of the most common drugs we use in anesthesia. And in the operating room environment and in the hands of anesthesiologists, we're trained to use fentanyl. We're experts with fentanyl. In fact, I've given it to probably 20,000 people in my career or more. And so what separates fentanyl from other anesthetics and other opiates is that fentanyl is a fully synthetic, highly potent opioid, I should say, because it's fully synthetic. So it's an analgesic, so it's a pain medication. It's about 100 times more potent than morphine, and it actually is unique in that, and it's very different from morphine in that it's very what we say about fentanyl is that it's very hemodynamically stable. So we can give fairly large doses to individuals, to patients in that operating room environment, and it doesn't change their blood pressure or heart rate. And it's a very safe drug to administer in that environment. So fentanyl is interesting also in that it can actually cause unconsciousness. It can actually be used as a complete anesthetic agent. So not only does it provide profound pain management and analgesia, that's our word for it, for pain management, but it also can, at a certain dose, it actually causes unconsciousness. This is different than morphine. Morphine is actually a kind of an unstable opiate in the sense that when we give high doses of morphine, it actually causes the blood pressure to drop so profoundly it can actually harm the patient. And so fentanyl, when it was first introduced in the 1960s, completely revolutionized surgical anesthesia and medicine because it changed it changed the types of procedures that we could safely do for patients. It dramatically enhanced that safety compared to morphine. We were actually limited by morphine. And some of the other anesthetic agents we use that folks are probably familiar with are propofol. That's the most, very common medication that we use to have a patient go off to sleep. So it's we call an induction agent in anesthesia. So it causes sedation. It provides sedation. And then we usually use fentanyl in combination with propofol to blunt some of the fight or flight response that the body tends to go through whenever someone goes through a surgery. And so that's one of the reasons why we use fentanyl. And it's a life-saving drug in the operating room.
Okay, I feel a big but coming. But
So this is where we run into problems with fentanyl. Now, fentanyl, and this is what I can tell you as an anesthesiologist. In the beginning of my career, I was trained to do cardiac anesthesia. And so those are individuals who are coming in, they're coming in for bypass surgery. They're very ill. They have heart and vascular disease. These are very, very challenging patients to work with because they are so ill. And so what anesthesiologists noted when we first started to use high dose fentanyls for this type of surgery, for cardiac surgery, was that, at low doses, fentanyl acts like any other opiate. It causes, it gives you pain management, and it also causes respiratory depression, so it can slow the breathing down. Now, when you get into higher doses of fentanyl, literally what happens is it freezes the chest wall muscles, and it can close the vocal cords. And we call that laryngospasm, but it can close the vocal cords, and that vocal cord closure is sustained. Now, the reason that that's dangerous is that it's basically, once those vocal cords close, no air comes in, no air goes out, right? And so we're trained to deal with that, and we can give a muscle relaxant through the IV that relaxes all the muscles, including the vocal cords, and we can actually put in a breathing tube, and then there's no problem. So it's very safe. We expect to deal with this in the operating room, but that's the difference between fentanyl and morphine-derived drugs. Morphine itself and morphine-derived drugs actually don't have this effect, and we call it wooden chest syndrome. And so morphine and morphine drugs, derived drugs, do not cause wooden chest syndrome.
so All right, we're going to walk me through this again, right? So
Sure.
if I
Sure.
take too much, if too much fentanyl enters my system, you said it freezes up the chest wall,
That's right.
right? And then
Yeah,
closes the vocal cords.
that's right.
But you're standing right there.
Right. And so I'm standing right there. So that patient's going to be safe. I know to expect this. I'm actually monitoring their breathing because I'm actually helping them. At this point, the patient's usually asleep. They're usually unconscious, and I'm assisting their breathing with, with, like you see in the movies, with, the mask and the bag. I'm helping them breathe. Now I can actually feel when their chest wall gets tight. I can feel when it becomes harder to mechanically ventilate that person. And so once I start to sense that that's happening, I know fentanyl is causing that. I start to administer the muscle relaxant through the IV. And within seconds, all of those things reverse. And I'm able to control the person's breathing again. And then ultimately, then I'll put in a breathing airway for them so that way they're safe. So that's what we notice. And that's what we see with fentanyl. And now, obviously, the thing about that is that, if I were to step away from that patient, you know, and that is occurring, it's lethal. It's actually a lethal effect because the vocal cord closure is sustained. And within usually about, 60 to 90 seconds, the blood oxygen level really goes down by about 60 to 70%. And at that point, that's when the body becomes depleted of oxygen. That's when the heart starts to malfunction. The electrical system in the heart starts to malfunction, starts to miss beats. And then that can lead to, the heart stopping
So
ultimately cause death. Yeah.
so you've got a minute to a minute and a half to counteract the effects of, well, if it's okay to say this, fentanyl overdose.
Sure.
Uh, but you're not on the street.
Right. That's right. That's right. And the other thing too, without getting too complicated or too technical here, Mike, I could talk about this all day long, but the bottom line is this, is that, we also take other precautions when somebody comes in for surgery. We provide, 100% oxygen for them. We pre-oxygenate them. So they actually have an exceedingly high level of oxygen in their bloodstream. And so even if I were to step away or things got complicated, we bought about 3 to 5 minutes of safety margin for that patient by providing that oxygen ahead of time. So this is all really well thought out to make sure we optimize safety for patients. And again, I just really want to emphasize fentanyl is one of the safest drugs that exists in medicine in the operating room in that controlled setting. It is exceedingly safe. But going out to the street, people are obviously not pre-oxygenated. And when someone's vocal cords close, it's essentially however long they can hold their breath. That's about as long as they're going to survive.
Wow.
And I know, it's like lightning. Now, the other thing to remember too is that, there's the thing with fentanyl is that it has a very narrow range where this effect occurs. So if somebody takes, literally like the equivalent of 1 grain of salt of fentanyl, that's enough to probably cause respiratory depression, but it's not going to kill them. You go to 2 to 3 grains of salt, then that person is probably going to start to have chest wall rigidity, and they're probably going to have problems with their breathing. You go to 4 to 5 grains of salt, right? Then you're in the actual target range of fentanyl-induced vocal cord closure and wooden chest syndrome. And so it's such a narrow margin. And that's why this drug is so dangerous, because it is so potent. And how can somebody, discern, 1 grain of sand or grain of salt from 5 grains of salt in a powder or in a pill? It's
How
not.
do you do it? How do you do it or how do the pharmaceutical people do it? I'm assuming that the dealers aren't doing it this way.
No, no, they're not. They're not. I mean, what I can tell you is, when I get fentanyl in the operating room, it comes from, it's manufactured by a pharmaceutical company. It comes through the pharmacy in the hospital, and it comes in a vial that has a specific concentration, right? So in most cases, it's, 1 cc or 1 ml of fluid has X number of micrograms of fentanyl in it. And so I know exactly how much fentanyl I'm drawing up in a syringe. I know exactly how much fentanyl I'm administering to a patient every single time I administer it. There is no guesswork at all. Whereas in, street drugs, you have no idea what's in there. And and at this point, I should tell you, I started off, I you had some really good questions here for me that I wanted to address. And one of them is that, the reason we'll probably get into this in a little bit here, but I transitioned from anesthesia after 20 years into addiction medicine. And I actually did an addiction medicine fellowship at OHSU here in Portland, Oregon at the Health Science Center. And I've spent the last 7 years actually treating folks for opioid addiction. So I've talked with many, many, many folks who have used fentanyl, have survived fentanyl overdose, have witnessed fentanyl overdose and death. And what I can tell you is that, what these individuals tell me is that, when they use fentanyl, it varies so much, even from if it's the same dealer from batch to batch. And so many times they really don't even know what they're getting.
Well,
And it's
makes sense, right? I mean,
right,
they're not
sure.
getting it from, I trust that the drugs on the street aren't coming from your hospital pharmacy.
Right, they're not. They're not. I mean, there are probably some places where drugs can be diverted, but the most of what is actually out there in the world in the community setting is, illicitly manufactured fentanyl. It's made some other place and it's not made by a pharmaceutical company. Or diverted from a hospital. I can tell you that.
Yeah, we had an agent on a while back, Randy, that was talking about one of the things, no matter, what you read in the paper, the political deals are, we have not slowed down the analog and the various chemicals that go into it. So while we may slow down, fentanyl itself, the analogs that go to making it haven't been slowed at all.
That's really true, Mike. And the thing is that, gosh, I have so much information I want to share with you.
Go.
I mean, the bottom line is that, yeah, these precursors, essentially, this is what makes fentanyl. Fentanyl is probably going to be with us for a long time, unfortunately, because the precursors, it takes 2 to 3 precursors, you put them together, you provide heat, and suddenly 4 hours later, you've got fentanyl.
Mm-hmm.
And this is very different than, plant-based opiates, because you don't have to grow anything. You don't have to process anything. It's really just putting these precursors together. And it's so concentrated that 1 kilo, 2.2 pounds of fentanyl is roughly about 1 million doses.
Oh,
And not just 1 million doses, it's 1 million lethal doses if it's used if it's used inappropriately. Yeah.
wow.
So
Well, if I'm using it on the street, thank goodness we have naloxone out there.
yes, I will say
But
this. Yeah, yeah. So I guess that kind of segues into what brought me into this field,
yeah,
really into this field. And so, so as I mentioned to you, we had in this small town that I lived in, and we had this series of fentanyl overdose deaths. And we all know each other in the medical community. And I can't remember if it was a paramedic or one of the medical examiners who asked me, several weeks later after these deaths had occurred, he said, hey, Randy, come here. You're an anesthesiologist. You get fentanyl, right? And I'm like, yeah, I get fentanyl all the time. Well, hey, I just wanted to ask you a question. This is the first time we've all seen heroin overdoses and opiate overdoses. We've never seen fentanyl overdoses before. And this is the first time we've seen 3 in a row. And I just want to ask you, does fentanyl cause seizures? And I said, no, fentanyl does not cause seizures. Why would you ask that? And so what that person described was, they said, well, we found each of the bodies, they were in these really weird contorted positions, like they had a seizure. And so I walked away from them thinking, well, fentanyl doesn't cause seizures. I know that for a fact. But then later on that day, I was on a run or something, and my mind was just wandering. All of a sudden, like a lightning bolt, I thought, oh my God, wooden chest syndrome, folks are having in the community setting. If they're having that, this is going to be a catastrophe. This is going to be so awful. So then the first thing I thought, like Mike, is like, hey, we've got naloxone. That should work. It'll be okay. So immediately I came back from my run. I got onto PubMed and which is, I don't know if you're familiar with it. It's a worldwide database that has all the medical and scientific literature in the world. It's all right there in PubMed. It's an incredible resource. And it's free. It's available to anyone. And so anyway, so I went on PubMed and I'm looking for naloxone, fentanyl, wooden chest syndrome. And I'm looking, and I'm not seeing anything. I'm not seeing any good studies where somebody has shown very clearly that naloxone antagonizes wooden chest syndrome. So I'm looking in the clinical literature, the human literature, not seeing much. Then I look in the animal research, and I see that, yes, someone has actually looked at wooden chest syndrome, but no one looked at this vocal cord closure phenomenon. It had been completely just not even touched in research. And so I thought, oh my God, we don't really know if naloxone works. No one knows the mechanism of fentanyl-induced vocal cord closure. What's going on? And so I thought, well, before I get too crazy here and making plans of what I'm going to do, I'm going to call some folks that I know in addiction medicine, and I'm going to ask them. I mean, obviously they have to know about wooden chest syndrome. This is a common phenomenon with fentanyl, right? So I'm calling up there like, Randy,
what are you talking about?
Wooden boat, wooden shoe, what? And we all know that respiratory depression is how people die from opioid overdose, Randy. What are you talking about? And so then I realized that they didn't know about it. And I knew if they didn't know about it, their patients definitely didn't know about it, right? And so then that kind of pushed me to shift gears to think about, well, okay, all right, I'm a logical person. I have to prove my hypothesis one step further. And I need to talk with people who are actually using fentanyl. Now, if I talk with them and I ask them if they've overdosed on fentanyl or witnessed a fentanyl overdose, and they describe wooden chest syndrome to me without knowing about it, then I know that I need to be doing this. And so the place that I ended up landing was, I came to Portland, Oregon. And Portland already had a significant opiate issue, an opiate problem, but it was most commonly heroin. Mm-hmm. And so I came to Portland in 2017, and I just started talking to folks. And I went downtown. I started just talking with people. And what I learned from some of the folks that were using fentanyl that had either overdose or witnessed an overdose, they started describing wooden chest syndrome to me almost just textbook, without me providing any information to them. And I said, well, is it different than with heroin? Oh yeah, it's really different. My buddy, he overdosed. I mean, it was like immediate, it was like lightning. And all of a sudden he looked like he was having a seizure, and he just fell out on the ground and he was unconscious. And I've never seen that before. And so then I knew, and that's what wooden chest syndrome actually looks like when fentanyl overdose occurs. And so at that point I thought, well, okay, I'm going to get some additional training. There was an addiction medicine program fellowship at OHS, Oregon Health Science University. So I joined the program. It's just 12 months. So I did the program, and knowing that I would need to find a research team that I could work with. And so pretty shortly after getting there, I met up with Dr. Aaron Janowski, who is he's a neuropharmacologist there, and he was the former head of the Methamphetamine Research Center. And Aaron was like, hey, Randy, this is fascinating. I've never heard of this wooden chest thing, and this is crazy. That we all know that it's respiratory depression, but you're saying it's something different. Okay, how can we help you? How can we figure this out? You're not an NIH researcher. You're just a clinician walking off the street. What are we going to do? And how do you propose that, these are the experiments we can do, but how do you propose to do this? So Mike, I bootstrapped it. I started, begged my wife to lend me some money. She made me sell a couple of guitars, and I'm a musician. So she made me sell a couple of instruments, and, that became the beginning of TMT. So we started doing some of the binding assay studies where we look at what fentanyl actually binds to, and with human receptors that we grow up in petri dishes. And we were able to show that fentanyl not only binds opioid receptors, just opiate receptors, just like we would all know, but it also binds these off-target receptors and adrenergic receptors, adrenaline receptors. And so anyway, so we said, okay, well, this is interesting. And so then Aaron said, well, Randy, this is interesting, but where do we go with this? So he said, hey, we have to develop an animal model. So how are we going to do this? So I developed, with my team there, we developed a translational animal model where we can actually, that replicates the symptoms that we see, the effects that we see in humans of wooden chest syndrome and vocal cord closure. We were able to replicate that in an animal model. And then we've used that as a platform to identify the targets in the brain that control this vocal cord phenomenon that fentanyl causes. And we've also been able to find several molecules that can reverse this effect of fentanyl. And so right now we're in the middle of seeking out more funding now we're funded by NIDA, the National Institute on Drug Abuse. We basically, that first set of data that I was able to get with Aaron's lab, we use that to apply for grants through the NIH and NIDA. And they have been exceedingly supportive of this project now moving forward. And so we're basically in the middle of drug development and drug discovery. We're still in the preclinical stages, so in the animal stage. But we hope that here over the next couple of years, we will, and really over the next 12 months, we're about to turbocharge our program here. But we're hoping that we'll be able to move forward with some of these molecules through the FDA and hopefully be able to get more effective therapeutic agents out into the world. And one of the things that we didn't talk about, and is that in developing this animal model, the first thing that we wanted to do is we wanted to see whether or not naloxone was effective for reversing this vocal cord closure phenomenon. And what I can tell you is that at low doses of fentanyl, this is really important for your listeners and for your audience. I'm not saying that naloxone doesn't work. What I'm saying is it has limits. Mm-hmm. And so for low doses of fentanyl, naloxone works great. It reverses all of the fentanyl effects. But at higher doses, fentanyl, the higher dose effects of fentanyl with the airway, with the upper airway, with vocal cord closure, those are actually resistant to naloxone. And so if you give naloxone immediately after somebody suffers from a fentanyl overdose, it's probably going to work. It may work, but you're going to need higher doses than normal of naloxone.
Well, I hear that from EMTs and law enforcement. I mean, every time I'm talking to people in law enforcement, they're like, it's everywhere. And now people are going straight to fentanyl now. And, used to be, I've been present when somebody was having an overdose on an opiate and one puff, boom, boom, and they're talking to you. So it clearly, but that's not been the case with law enforcement in the last several years, right? It's like we're having to give multiple doses, and even then it may not be successful. So what you're looking for, Randy, if I'm right, is a partner to Narcan that might be more effective fentanyl since it's ever present and, as you said, not going away.
Right. And so, so that's exactly what we're looking at, because fentanyl has two separate effects, Mike. One is it causes respiratory depression. You heard me on this, just like any other opiate, but it also causes this mechanical failure of respiration from airway obstruction and from chest wall rigidity. And so that is a completely separate phenomenon, physiologic phenomenon, and it's controlled by a completely different set of receptors in the brain, not opioid receptors. And so we're still trying to isolate unfortunately, the molecules that we're using hit multiple targets. So we're still trying to isolate the exact targets involved. And that's what's taking the time here. But they're two separate targets. And so ultimately the ideal drug for reversing fentanyl effects at all levels will be a combination therapy of some kind. And so yeah, that's the thing, is that naloxone is very effective for low doses of fentanyl, but once you get into those higher dose ranges, and once you extend time, in our animal model at 45, so if you give it immediately after somebody overdoses with high dose fentanyl, it can reverse these effects of fentanyl, all the effects of fentanyl. You wait 30 seconds, that response rate goes down by about 60%. At 45 seconds, 45 seconds, you're at 10%. At 60 seconds, it's 0. So, yeah.
That's a minute.
Yeah, it's a minute. It's a minute. So it's like lightning. And that's, so ultimately our goal is to develop new therapeutics that are safe enough for individuals to carry around, just like naloxone or nasal Narcan, and they'll be able to use it in conjunction with nasal Narcan or separately from nasal Narcan. And
Wow.
it will be able to, and they'll be able to use it for any type of opioid, overdose, whether it's fentanyl or heroin or any other morphine-derived alkaloid. So, and
I hope you'll consider coming back and talking to us as your research continues. Uh,
I would love to, Mike. And I realized, you said 30 minutes will go really
well,
fast. Sure did.
I know. The hardest thing, Randy, for me with these is when I have somebody I really like talking to is going, oh, looking at the clock. And sometimes they go over 30 minutes, but we know that there's a listener fatigue, right? People
Oh,
are
yeah.
listening in their cars, they have to go somewhere. But I'll let you go with this though. And it's something that you said or that I read that you said, this information is important to share. What you
Yes.
just shared is important to share. Now, we have a number of therapists that are listening. We have a number of treatment professionals, as well as lay people who have and are using and recovering folks. How optimistic are you that the crisis we're currently going through can turn around with research and education?
I'm so glad you asked me that question. I don't mean to paint a picture of doom and gloom here. This is the only way that we are going to find the effective treatment and therapeutic solution for fentanyl is by understanding its mechanism. And we've reached that point. So at this point, I can tell you I'm very optimistic that we will be able to move past this fentanyl crisis. We will be able to save lives. And that 100,000
Yeah.
patient per year death mark will go away at some point in the near future. But it begins with education, to like today, sharing this information with your audience and with other therapists and other physicians who are out there and medical providers that can share this information with their patients. The other thing too is just to really point out that fentanyl is a highly addictive substance, and it is unique in that it's highly addictive because it has a very short half-life. So it's very
Hmm.
fast on, very fast off. It also causes something called hyperalgesia, which is just as bad as it sounds. It dramatically increases the pain that someone can have. It lowers the threshold for physiologic pain. And so when someone goes through withdrawal on fentanyl, it's particularly horrific. And so those feeling the physiologic symptoms of withdrawal are significantly elevated with fentanyl. And the other thing too is that fentanyl stays on board in the body, in the muscle and fat compartments in the body for up to 30 days. So it stays on for a really long, long time. And so it makes it challenging for us to treat folks who come in who are actively using fentanyl. What I would say is that it's important to know that there is medically assisted treatment like methadone and Suboxone, which can be very effective in helping someone to pull themselves off the harmful path of using fentanyl on a daily basis. And then, and then over time, as the brain heals, that's the other thing too. At some point, I would love to talk to you and to your audience more about what the nature of addiction is, actually the neurogenetic process of addiction. But the bottom line is that when that person comes in and makes the choice to shift off of fentanyl, they're saving their life. That first step is saving their life. So if anyone is actively using any kind of drug at this point, because it's basically in everything.
Yep.
And I can tell you that for a fact, because our lab, actually, Aaron's lab, is contracted with the DEA. They send us samples from hotspots all around the country. Everything has fentanyl in it, some form of fentanyl. And so if anybody's using drugs that they're at risk for being exposed to fentanyl. And all it takes, again, is just that 2 to 3 grains of salt of fentanyl in anything that they're using, and it's lethal. Whether they smoke it, inject it, or take it orally, it becomes lethal. So get into treatment. There is good treatment available. Don't, know that help is there. There in Portland, Oregon, we have CODA, we have Central City Concern, which are incredible facilities and help thousands of people who are here suffering from opioid use disorder and other addictive substance use disorders. But bottom line is, I would love to come back and talk with you more and provide more information to you. Bottom line, if you see somebody have an atypical response to an opiate, they're probably using fentanyl. If they look like they're having a seizure, if it's immediate in onset, that they become unconscious, call 911. You got to get backup. You got to get the cavalry there. And then you give naloxone and you do the supportive therapy that you need to do for helping with their breathing and trying to get that naloxone on board. And it's going to probably take multiple doses. So just be aware of that. Carry multiple doses of naloxone with you. And so anyway, with that, thank you so much for having me today.
Thank you, Randy. And instead of doom and gloom, I found that you're the opposite. This is innovation and initiative. So thank you for your work. Thank you for the research, and thanks for taking the time. You all know this. We're going to put links to TMT-rx at the bottom of the podcast. Thanks for being with us today. And for those of you listening, we always invite you to listen in next time. And until next time, stay safe and stay informed.